really what it all comes down to is all of this neurological afferent input into the neuroaxis. Okay? You've got all this good information coming in, but you've got bad information coming in, you got bad output. Bad output is muscle spasm, postural distortion, pain syndrome, stuff like this. It's really all about abnormal position, abnormal movement, causing constant abnormal afferent input into the system that causes a bad outcome. What is that? Garbage in, garbage out. It kind of reminds me of this little commercial I like.
A very close call. Could have gone either way. It was right on the line. Well, Person's not too happy with it, I can tell you that much. He's beating him like a rented mule. And the ref's just tuning him out. Boy, where do you train to take a beating like that?
He said, when's that part's gonna get paid? Look at the part! It's been 3 weeks! 3 weeks! I don't think I could have married Dawn Hoffman. And would it hurt for you to say that you love me once in a while?
You know, I can identify with that commercial for a couple of reasons. Well, okay, hey, wait a minute now. I am a high school football official. Yeah, what was he thinking I was going to say? Dr. Bo and I, one of our motivations here in creating this book was that we got to get this information in the hands of doctors around the world. We can't be so short-sighted that we just want this southeastern group here. And I know there's probably some doctors that have traveled further than that, but we got to get this word out to the world, okay? The first book is on the science behind the subluxation. This is the why, this is the how of the subluxation and its correction. Last thing I want to say about the strength of the dentate ligaments. Here is a paper on cervical on basically cervical spondylotic myelopathy. Here's the thing to look at. With CSM, as we'll call it, you have a spondylitic rigid bar in the back of the disc, and it's just a really terrible spondylosis right inside the neurocanal. It goes all the way down. And what happens is it can push and cause compression on the cord. Okay? And so here you can see it. It's pushing on the cord, and here's the dentate ligaments. See how much tension they're under? Because the cord's pushed and they're being tugged on. So here's what they did. They said, okay, we're going to go in there and decompress the area like they do, and we're going to do a laminectomy. We're going to chop off these lamina. Okay? But they find, wait a minute, it's not getting the job done, because look, it's still compressed. Because why? The dentate ligaments here. So look closely, folks. You see this right here? What they do? They cut them. They snipped them. And now that joker could release. So tell me, are those dentate ligaments strong enough to deform the cord? I would think so. Here we have a diagram from the new book. And one thing you see here is the dorsal horn. You see how this guy looks weird? See the horn here, the dorsal horn? Look how big it is. It's got big old giant Dumbo ears, right? Because that's the way it is in the upper cervical cord. The dorsal horn is huge. And of course, this is really where the trigeminal neuralgia cases come into play because of the spinal nucleus of the trigeminal nerve and spinal tract of the trigeminal nerve. And there is some movement that occurs between atlas and occiput. It's not much. It's only a little bit. But the thing you have to keep in mind is that it occurs at the extreme of the range of motion. So in other words, as I move my head or neck at this point, I'm not moving anything between atlas and occiput. But at the extreme of the movement, there's a little slippage. There's some different studies that give you different ideas on this. But I like Campanji, and this is an illustration from Campanji's textbook, who is one of the leading medical physiologists in this area, kinesiologists. And what he shows here is that there's about 3 degrees of slippage that occurs between atlas and occiput. And that's probably what I would say is about the average. But keep in mind, it's at the extreme of the movement. Now, does this invalidate our theory that a 3/4 degree misalignment between atlas and occiput is enough to create neurological interference? And the answer is no, it doesn't. Because first of all, we'll talk more here in just a second as far as how this slippage actually creates the neurological interference. But if you put your head in the extreme of motion, and I'm talking about this little lateral flexion that occurs, does this mean that you're subluxated? No. Does it mean that you're creating some neurological interference? Probably. Probably. As a matter of fact, if you kept your head in this position for any length of time, you'd develop symptoms and you would have problems. I know Dr. Grosick mentioned it in some SSCP studies where they had checked patients with their neck in different extremes of range of motion and actually created disturbance in the SSCPs. But the fact of the matter is, we have an orthogonal norm that we're striving to achieve. And orthogonal being that the head and neck is perfectly vertical, the atlas is horizontal, the C2 spine is in the center. This does not necessarily mean every single patient must be orthogonal. Coupled motion. Here is the key. We talked earlier about how there's a little slippage when we move our neck through the extreme range of motion. But in normal articulations, what happens when you laterally flex your spine or rotate your spine? You're not dealing with pure lateral flexion. We're not dealing with just the atlas or C2 moving in a lateral flex fashion. What happens in normal human spine is something called coupled motion, meaning when I bend my spine to the right, I'm not just getting lateral flexion, I'm getting a little rotation and a little translation. You understand? And why does this happen? Well, there's different ideas on why it's important kinematically, but we propose that part of this is something set up in the system to help reduce tension on the nervous system, especially when we're dealing with the upper cervical spine. If we were dealing with pure lateral flexion, it would almost be like creating pure laterality, you see. But this kind of buffers and kind of reduces the effect of the slippage that occurs between the atlas and the occiput. Here's the big one. Here's the big guy. Here's the one that probably has more to do with what we see in upper cervical subluxation care from a receptor standpoint than anything. And that is, what is this here? Muscle spindle. Do you know that scientists say that the muscle spindle is the most complicated, complex organ in the human body? Second to the retina in the eye. Second to the retina. The most complicated organ in the human body is something that sits in the muscles of your body. It's a muscle spindle. Muscle spindles are found throughout the muscles, all throughout the body. And the thing that's so important about them is the fact that what makes them very interesting in the upper cervical spine is how dense they are in the upper cervical muscles, what we'll call the suboccipital muscles. Okay? Here's an example from a study from neurology in India. As an example, they're talking about the superior oblique, superior inferior oblique, and the rectus, captus, posterior, major, and minor. And you can see the densities here are 190, 242, and 98 in each of these muscles. What does that mean? Well, in comparison, the density in the trapezius muscle is 2.2 per gram. So why is that? Why would we be created with such a finding like that? Well, there's reasons for that. But here's something that